Hello, everyone. Thank you so much for joining us for another Health for the World Radiology webinar. Today, we have the honor of having Dr. Alyssa Cubbison join us to talk about asymmetry and architectural distortion in breast imaging. Dr. Cubbison is an assistant professor of radiology at Ohio State University. She completed her radiology residency at Loyola University, followed by a breast imaging fellowship at Northwestern University in Chicago. Please feel free to write your questions in the Q&A box at the bottom of the screen, and we'll get to them in the last 15 minutes of the lecture. Dr. Cubbison, thank you so much for joining us today, and we look forward to hearing your lecture.
Great, thank you for that, and thank you all for joining me today. It's really an honor to speak with you. I am a breast radiologist, as they said, so I do this, day in and day out. Don't hesitate whatsoever to write a question in the chat or even just shout it out during the lecture. I certainly want this to be as educational and meaningful for everyone as possible. So I'm on your time as far as I'm concerned. So don't hesitate regarding that. So we'll go ahead and get started. I am discussing asymmetry and architectural distortion today. These are mammographic findings for those of you that haven't had too much experience in the world of breast imaging. These are very common findings that we see on mammogram. Asymmetries and architectural distortion are, they are, mammogram findings that are often reasons that our patients are called back from a screening exam. So we'll go over a little bit what to expect from both of them and then how to work these findings up. Some objectives from today, we're hopefully going to be able to recognize the different types of asymmetries as well as architectural distortion on a mammogram. Hopefully be able to formulate a differential diagnosis for both asymmetries and architectural distortion. And then being able to work up diagnostic images when we do come across these findings. So I thought to compartmentalize them because we have two things to cover with the asymmetry and the distortion. So first, we'll just be discussing asymmetries because they are different findings. So if you're not familiar with our American College of Radiology BI-RADS Atlas here, this is our gold standard reference for any breast imaging related questions that we have. So it's very comprehensive and we often refer to it with any of our questions. So according to our BI-RADS Atlas, there are 4 categories of asymmetries. There's global asymmetry, a developing asymmetry, a true just asymmetry, and then focal asymmetry. We will go through all of these if you're not familiar with these terms. So starting with asymmetry, this is going to be a finding that seems discrete from normal breast tissue that we see on only one mammographic view. So by definition, if it's an asymmetry, we are only seeing it on either the CC or MLO. If you see something you truly believe to be a correlate for this finding in 2 separate mammographic projections, then you no longer can call it an asymmetry. That's going to be considered a focal asymmetry, but we'll go on to that. But just for sake of understanding that this is by definition a one view finding, it can look very similar and often does represent normal breast parenchyma, but there's something about it on the mammogram that lets us think that this is discrete and potentially not just due to breast parenchyma. It lacks convex borders, so sometimes you'll see what looks like a mass that you can only see on one view, but usually asymmetries lack the convexity that we see in a typical mass. It may or may not contain interspersed fat. Usually, if we are seeing interspersed fat, then that helps us maybe lean a little more towards it just representing normal parenchyma that's in somewhat of a discrete pattern. But in general, it doesn't have to or not have that interspersed fat. And then it also occupies less than 1 quadrant. So the differential diagnosis for asymmetries is very long for any office fans out there in the audience, but it's long. And certainly if you're just looking at a screener, it's pretty difficult to definitely differentiate any one of these things. More information would need it to be had. But I think the big takeaway I wanted from this slide is that most of the findings of asymmetries do represent normal fibroglandular tissue. We know that based on robust literature, that specifically 80% of them called back from mammography are usually due to tissue. So as I said, this 80%, now these are those that are found on screening exams. So again, not only are they, benign, but they actually 80% of them represent tissue. So even more of them are ultimately benign than the residual 20%. But so they're definitely the type of thing you really want to scrutinize in order to prevent an overcall of a patient, to prevent a false positive and unnecessary anxiety and cost to the patient. But certainly cancer does present in this way. We'll go on to discuss more about that. So it does justify a callback if you really believe it to be a true finding discrete from normal tissue. Just as another reference, to juxtapose an asymmetry from masses, calcifications, and something called a developing asymmetry, their positive predictive value on screening mammograms are higher. So 9.7, 12.7, 10%, 7%, versus the asymmetry, they have lower positive predictive values, so 3.6 and 3.7. Certainly these numbers are nothing that need to be committed to memory for effective practice, but just to give you an overall idea that I think when you're kind of looking at something you may or may not want to call back, I think it's important just to have the context that we know that they're less likely to be cancer, but of course, that doesn't mean they shouldn't be called back in the appropriate setting. So how do we work these patients up? So we see something on the screener or the other exam that we find to be something that's worthy of a callback. Typically, there's of course different ways to approach it, but typically the most common way to work up an asymmetry is to pursue spot compression views. What's a spot compression view? For those of you that have not spent much time in the mammography world, so basically it puts more focal pounds of pressure on the breast in the area that was found to represent where the asymmetry was. So the intention, this is the example of a spot compression view. So we can see these are the two paddles that we have. There is absolutely part of the breast that is outside of the field of view, and that's okay. Presumably that's already been evaluated. What we want to do is put more focal pounds of pressure in one area. This allows us, if we do this, to disperse normal breast tissue. And if a finding is truly discrete from normal parenchyma, it will persist on these additional views. So if we add more focal pressure to one part of the breast and the parenchyma persists out of it, then we know that, okay, this is potentially something, versus in the majority of cases that it represented breast parenchyma to begin with. And when we add more pressure, all of the breast tissue disperses kind of uniformly, and we know that we can feel confident that that asymmetry was just breast tissue all along. There are some studies and some radiologists that don't rely as heavily on spot compression views with the advent of tomosynthesis. We'll go into more about what tomosynthesis is, but in general, it is sort of a shorthand, some refer to it as a 3D mammogram. So it does give us a better look of being able to distinguish tissue from not. So some practitioners don't utilize these spot compression views, but I think the takeaway for working these up is that you would either need spot compression or a tomosynthesis image to feel confident that you're trying to rule out the asymmetry. This was that article I just referred to you. It was by Zulli et al. Basically evaluating with the immersion of tomosynthesis around 2011. There was a lot of question of if they replaced the spot compression view. So this just kind of evaluated it. It didn't go so far as to say that, but they did say that tomosynthesis does improve diagnostic accuracy for a lot of non-calcified images, and it can decrease some of the supplemental mammographic views. So kind of interesting. So other purpose of diagnostic views, the intention of it is to help localize an asymmetry in the orthogonal view. So what that means is, as I said, asymmetries are truly one view findings. So if it's something you believe to persist and you want to ultimately pursue an ultrasound, it is certainly helpful for the sonographer to have a quadrant of the breast that you can localize the asymmetry to. So the intention is not to scan the entire breast when you're trying to look for something, or in this case, a hemisphere of the breast. So if you can really only isolate an asymmetry to either the lateral, medial, superior, or inferior aspect of the breast, because you only have one view, it's really not best practice to ask the sonographer to scan an entire half of the breast, so an entire lateral aspect. Usually we try to isolate our findings to a single quadrant. That's one, of course, out of respect of resources and time. And then two, I think it helps diagnostic accuracy. If you can really localize it to one area, you can feel even more confident and that you're really scrutinizing that one quadrant. So we do really try, even though it's a one view finding, we do really try as best we can to see it in the orthogonal view or in the opposite view. Some ways to do this are through utilizing a true lateral view or rolled CC views. So this is an example of rolled CC views. This is a finding that it didn't change as much on the medial view. It rolled significantly lateral on the lateral CC view. So we know that we can assume that this finding is superior on the mammogram. Even if you don't see, you can't visualize the mammographic correlate on the MLO view, these roll views help you at least guide the sonographer to something, to a quadrant, that is. This is true in the opposite. So if an asymmetry was only seen on the MLO view, then we utilize ML views or LM, or just lateral views. Basically, the MLO stands for medial lateral oblique, and that means that the X-ray itself was taken at an obliquity. The ML view means that it's a tangential X-ray beam. We utilize this MLO view because we know that we obtain more posterior tissue by obtaining an obliquity. But the ML view, although we sacrifice some posterior tissue, it helps us because it allows a truer representation of where a finding is in the breast. Also, it helps us, whatever the finding is, in relationship to the MLO view. So those of you may or may not have heard of the mnemonic muffins rise, lead sinks. Just a cute way to remember that if something rises going from the ML view, going from the MLO view to the ML view, then we can assume that that is in the medial aspect of the breast. So in this case, here is our finding in the MLO projection. We go to the ML view. This finding has risen. So we can assume, although we can't visualize this finding in the ML view, we can assume that it is in the medial breast. So we can tell the sonographer, please scan the upper inner quadrant of the right breast, and this helps our diagnostic accuracy. So moving on to tomo. So I kind of talked about two different ways to work up these asymmetries, these spot compression views, or utilizing tomosynthesis. Where we practice, I practice in the state of Ohio, and in many states of the United States, we do have legislation that covers this tomosynthesis exam for screening. So we do utilize tomosynthesis quite a bit, certainly in my practice and in many practices, just because at least screening, it's covered in most instances. So it's not an uncommon thing to utilize at all. You may have heard it referred to as a 3D mammogram. But basically what it does, the FDA approved it in 2011. So it's been around for a decade or more, but of course it's still, its utilization is still expanding. But basically it's an X-ray that takes a series of exposures moving in an arc, and it provides a more detailed image of a mammogram and allows you to actually scroll through the breast. Rather than a static 2D mammogram, which is just one 2D image, there's no scrolling, it's just that's the image. These allow for scrolling in slices that are 1 millimeter thick. Tomosynthesis decreases false positives, and this is by reducing the effects of overlapping breast tissue. So its advent has been very significant. As I mentioned, the false positives have decreased. So less women are being called back from their screening mammogram because we can isolate that a finding is due to fibroglandular tissue better on these tomosynthesis exams than we could with just standard 2D. But on the other side, and potentially more significant, is we're also catching more cancers utilizing tomosynthesis. So it does serve some pretty important purposes for us, not without its drawbacks. Just like anything, there's more radiation, more time. There is an added cost in many instances, but in general, it's been a really helpful diagnostic tool. I talked about localization. The diagnostic exam not only helps us better characterize an asymmetry, but it also helps us localize something. So the tomosynthesis can help us do that as well. So if you see here, this is where the arrow is. This is called a scroll bar. So basically, it's not perfect, but it does help us localize a finding, and it gives us an estimate of where it is in the orthogonal view. So if this is the MLO view, it does give us an estimate of where it may be on the CC view. So it will say, this is the far medial breast, this is the far lateral. So you scroll until you find something that's in plane or most crisp, as in this case. And then you can go down to the scroll bar and see, okay, it's central to slightly lateral left breast, presumably. Like I said, it's not perfect. It doesn't completely take away the other mammographic views, but it does really help. I think, you can say with a fair assumption that this is not in the far lateral or far medial breast. So it can somewhat help you localize that potentially this finding is more central to slightly lateral. This is a little esoteric, but I included it just because I mentioned it's not perfect. There are some reasons as to why localization with that scroll bar on the tomo isn't perfect. Basically, it assumes that the localization is based on the lateral view, and oftentimes our screening exams are utilizing MLO or medial lateral oblique. The true center may not be at the middle slice. So this is very dependent on nipple positioning being perfectly in profile. It assumes that the nipple is perfectly in the center, which if you've read mammography, just based on some anatomy and other factors, it's not always exactly centered. So I don't want to lose the forest for the trees here. I don't want to go too far down all of this, but just to give you an idea as to why sometimes it's not exactly perfect, but just to give you a general idea. So how do we manage asymmetries? So it can vary depending upon the clinical scenario. So I kind of will break down a few of the clinical scenarios and what BI-RADS we will assign them, and then how we typically manage them. So if spot compression views were found to disperse the asymmetry, I showed you those spot compression views, and one of the intentions of them is to disperse those tissues. If we find that the asymmetry just represented breast tissue, it really dispersed on the spot compression views, then we BI-RADS to them. So we don't we will just give them a 2, meaning it's normal benign tissue, BI-RADS 1 or BI-RADS 2. It was just normal, and they can return for their screening exam. So this is a different clinical scenario. So if an asymmetry persists on a baseline diagnostic workup with no sonographic correlate, so baseline meaning this is their first mammogram, we have no mammograms to compare to. We found that we did the additional views for the asymmetry. We found that it did persist, meaning we couldn't completely convince ourselves that it was just normal tissue. We sent them to ultrasound. We didn't see an ultrasound correlate. Those, according to our literature, are assigned to BI-RADS 3. BI-RADS 3s are what we consider to be probably benign, and we usually follow them with imaging. In this case, they would follow them with a mammogram because nothing was seen on ultrasound. Now, I did underline baseline because a key distinctive feature here is that this is the first exam. So moving on to our next clinical scenario, if the asymmetry is found to be new and it persists, so we have priors, it wasn't there before. Technically, according to our literature, we do BI-RADS for these, and BI-RADS 4 means we biopsy it. So unless you have reason to suspect that it's due to a probably benign factor, like maybe the patient provides the history that they fell and you have reason to think maybe it's just post-traumatic or hematoma, something like that. There are instances where fat necrosis can sometimes, you can follow those. But in general, if you find an asymmetry to be new and it persists, then we do biopsy them. If asymmetry demonstrates suspicious borders, AD stands for architectural distortion, calcifications, you can assign a BI-RADS 4 to that as well. So basically, this means that there's other suspicious things happening in addition to the asymmetry that allows you to think that this should undergo a biopsy. And then even if you don't see an ultrasound correlate, if you have stereotactic biopsy capabilities at your facility, then you can perform that type of biopsy. That's obviously not available everywhere, but if you do have it, they're not committed to sometimes they're surgically excised or they're just followed. So if you have that capability, then certainly you can utilize that. This was just an example of a case we saw at our medical facility. This patient, this was 1 MLO view of her left mammogram. This was a screening exam. So this is, I think, a nice example of the subtleties of an asymmetry. So this is all just normal fibroglandular tissue. As you can see, this, I know the circle is certainly faint, but I'll circle it with my cursor here. This was found to be somewhat discrete from the rest of the parenchyma, and this was called back. Additional diagnostic views were performed, and then they were sent for ultrasound. This irregular shaped, very ill-defined shadowing mass was seen. It is, certainly the borders are hard to discern, really hard to say what is discretely the mass, but obviously you can see this looks very different than the rest of the surrounding normal breast parenchyma that we see here. So this patient did undergo a biopsy, and this was proven to be invasive lobular carcinoma. I did want to touch on invasive lobular just for a second here because it is oftentimes what the cancer that we worry about missing, so to speak. So I touched on how most asymmetries are benign and the vast majority are tissue. And of the ones that are not tissue, most of those are benign. So why do we bother calling them back? Well, although asymmetries don't have to be invasive lobular, that's always the etiology or the pathology we're most worried about missing because they pathologically lend themselves to just more subtle imaging. I say that because, so they arise in the lobular epithelium. In a classic invasive ductal carcinoma, so our most common type of breast cancer, incites what's called a desmoplastic response pathologically. That often explains the distortion and the spiculated appearance that we see. Lobular carcinomas don't do that. They don't incite a desmoplastic response, so we don't usually see those very obvious, helpful mammographic findings of the distortions and the spiculations. They usually have a non-cohesive growth pattern. They sort of grow more linear. I do have an image of it here. I think this is going to be worth much more than my words would be. But you can see these blue stained cells here. This is the lobular carcinoma in and of itself, and they sort of grow in a very respectful linear way. So as you can imagine on imaging, it grows in a similar kind of pattern that you may see from just normal breast parenchyma. So again, I just kind of wanted to linger on this for a moment, just so you can, this is definitely high on the differential if you're going to pursue a biopsy. Okay, so I just talked for 20 minutes about asymmetry. So I am going to move on. I appreciate your patience. I know that's a lot. And so the difference between a asymmetry, where I said that was a one mammographic projection view. So if we see here, we have the CC, the MLO, it's seen only on one or the other. Focal asymmetry is seen on both views. So you see this in both, there's a correlate in both the CC and the MLO. How this is distinguished from what we call a mass is that it often lacks the convexity that we say when we see a mass. So what's our management? The workup is going to be similar to an asymmetry that I already talked about, so I don't want to belabor the point, but oftentimes we utilize spot compression views, tomosynthesis, and then you may or may not pursue an ultrasound based on what you see on the mammogram. So focal asymmetries without an ultrasound correlate on a baseline exam, much like the asymmetries that I talked about, also indication for BI-RADS 3s. Based on our literature, we say that there's a less than 2% chance of it being cancer. So that 2% is sort of our magic number that we utilize to say we don't want to put the patient through the cost and certainly the risks of a biopsy, because it is so likely that it is not cancer. So we usually BI-RADS 3 these patients and recommend follow-up. So the same management of focal asymmetry as mentioned for an asymmetry, and again, baseline exam. So going down to the third type of asymmetry, this is going to be a global asymmetry. So this is asymmetric breast tissue that involves at least one quadrant or more. So this must be seen on two views, and there's no other superimposed suspicious findings that are seen, meaning no masses, architectural distortions, calcifications. If it meets all that criteria, this is considered a normal variant and it's considered to be benign. So in this case, although you see this sort of asymmetry that looks asymmetric to the other side, it does look like it's kind of in one quadrant on the MLO, and that's just because they're superimposed on each other. But we know it involves more than one quadrant, and so this can actually, and if there's no other suspicious findings, we can feel comfortable calling that a BI-RADS 2 and a normal variant. And so, yeah, just big take home from these is you don't need to call these back from screening mammograms. They can be considered benign, and we can spare the patient an unnecessary callback. I think sometimes it's a little hard. I know it's hard for the residents and certainly anyone in practice to be really comfortable calling something that looks so asymmetric to the other side benign. So I included this, and again, it's not to educate by intimidation. We can all, mammography can be so subtle, and we can certainly, put scary cases to force us to overcall many things. But I did think this was a good case to highlight because it does show sort of the juxtaposition of what I'm trying to say is that this was a malignancy, but there's other secondary findings to explain. So she has thickened septa that's asymmetric to the other side. Her nipple is inverted, and she actually has skin thickening as well. So she does have other secondary signs to say, okay, although this asymmetry is considered global, meaning it involves more than one quadrant of the breast, she has other superimposed suspicious things. So of course, it doesn't meet the criteria for a global asymmetry. So I am going to emphasize this a little bit more. This is what's called, so the last of the 4 types of asymmetry I mentioned, this is going to be our number 4. So developing asymmetries are ones that are considered larger or more conspicuous than compared to prior. So I mentioned that new asymmetries or enlarging asymmetries, they usually get biopsied. So in this case, developing asymmetries have to have a prior because they need something to compare to. And we can see that it's slowly getting bigger. So in this case, we have 3 years of comparison. This is 1 year, and then this is the following year where this very subtle thing got a little bigger. And then in the second year, it got even bigger. This is a nice example where, although if you see this in a vacuum, meaning you see this just one static image, may not be the most suspicious, but in the context of having 2 other mammograms where it's slowly getting bigger, that's treated with a different threshold than it would be if you were just looking at one image without any priors. So this is not super common. In one study, 0.2% of screening mammograms show this, but it is worth a callback nonetheless. A study by Sickles found 6% of non-palpable cancers did manifest as developing asymmetries. So the positive predictive value of developing asymmetries is certainly higher than what we see from asymmetry or focal asymmetry. It can be a diagnostic challenge, but it's one example of why we emphasize to look at the trend views. So that's something that we will always advocate for. It allows us to really see the progression nicely. In one study I saw by Lung and Sickles, 12% of these were found to be malignant. So certainly, you know, a biopsy is definitely warranted in these instances. And as I said before, a lack of ultrasound correlate should not deter biopsy in these cases. And they should be treated with a higher suspicion than asymmetry because, as we know, you know, approximately 12% of these are malignant, and the positive predictive value is overall higher. You know, one obvious or common explanation we get for developing asymmetry is weight loss. So I included this slide just because it's an important piece of history to obtain, really for every mammogram. But this is one of the reasons that if a patient had significant weight loss, and that's why we're seeing an asymmetry look distinct, then that can be one explanation for it. Now, obviously, history is very important. You know, did it really just develop? Did development of it coincide with the timing of the weight loss? So obviously those are all things to be specific on, but it can be an explanation. So I have a case here. I think that'll be much more important than me just kind of going on and on about this stuff. So this was a 41-year-old that was recalled from her screening mammogram. If you can see my circle here, this finding was called back from screener. It was only seen in one view, not really seen in the orthogonal MLO view. So this finding was seen here, spot compression views, putting down that paddle, trying to disperse those tissues. This patient was then taken for ultrasound. Not a lot was really seen. It really did mostly disperse. Usually, if you feel confident that an asymmetry disperses and you don't, meaning it just looks like normal breast tissue, you really don't need to utilize ultrasound in those instances. This patient did. Breast density sometimes is a factor for when we do or don't, but I thought it was nice because although it dispersed, they were still sent for ultrasound, and we saw a really nice case of a cluster of cysts, a totally benign entity. And it's one explanation for why an asymmetry may press out, meaning, you know, it doesn't persist because of the pliability of cysts. So, you know, there was a true finding here to explain what we saw in mammogram that was separate from breast tissue, but benign nonetheless. So I thought that was a nice example. So this was a different case. This was a 50-year-old female recalled from screening mammography for a focal asymmetry. You can see here, it was this area in the upper outer left breast. And then, sorry, about that. So I kind of zoomed in here to 2019, and then we only had one prior to compare to, but you can see it certainly had increased compared to 2018. So it was called back. This was found to persist. This is a spot compression view with tomosynthesis. You can see here this persisted, demonstrated kind of spiculated margins here. I think you can appreciate that this is all just normal breast tissue, but this, the convexity persists. So this is not just normal breast tissue. And then when we pursued ultrasound, there is a hypoechoic irregular mass that we saw corresponding to this asymmetry, and this was found to represent cancer. So I actually showed this case already, so I can, but this was an asymmetry that was recalled from screening mammography in a 65-year-old patient. I didn't include the spot compression views, but here you go. This is them, and I think this is, even more subtle than the last, because I think the last one actually showed a true mass or, real convexity. There's no real convexity, but it does look not like normal breast tissue. This just has kind of weird, more spiculated looking borders. And it doesn't have that nice pattern that we expect from just normal breast tissue. And there's, some subtle distortion there as well. So this was sent for ultrasound, and this is when we saw the very suspicious looking mass. A biopsy was done of this, and we got the invasive lobular as we saw previously. So moving on to another case, this was going to be a screening mammogram. I thought this was another really nice example of a developing asymmetry. So we have a screening mammogram from the year 2020. This is going to be the year 2019. This was 2018. And as I show you here, just where the arrows are pointing, I think not only is this increasing, but each year it gets a little bigger. So when we see that, we sort of, again, this absolutely meets criteria for a developing asymmetry, and we take those more seriously. You can also appreciate kind of a slight skin thickening that may have been developing, unfortunately, for the patient. So that, helps clue us in too that this is even more warrant for investigation. So this patient was sent for ultrasound, and there was a hypoechoic irregular sheet mass with internal anechoic components, likely reflecting some necrosis. And this was found to be invasive ductal carcinoma. This is, again, I know I'll kind of just quickly go through here. This is another example of a developing asymmetry. We see here 2021, 2020, 2019, kind of slowly getting bigger on us each year. The tomosynthesis, I think, shows it quite nicely. So we have here a mass with associated architectural distortion. It's certainly very, very suspicious. Even if this were stable, this would be a suspicious finding, but also, even though it's slightly increased each year, not significantly, it's certainly a slow growing, has slow growing tumor biology, but, certainly suspicious nonetheless, and absolutely warranting a callback. Now, I showed a lot of cancer, and I wanted to kind of end with this case for asymmetry's sake, because, as certainly not everything is cancer, not every asymmetry is cancer. So in this case, this was April of 2021. This patient had a very impressive focal asymmetry in the lateral subareolar left breast. She did provide a history of falling on her bicycle with bruising of the left breast, which is, of course, very helpful because the imaging overlap of trauma and cancer is very narrow. So if we have history to suggest trauma, then that definitely helps guide our differential. So we thought as such that this was likely hematoma or trauma related. So we recommended a short-term follow-up within 4 to 6 weeks. So she then presented a month later in May 2021. And as you can see, it hasn't resolved completely, but certainly much smaller than on the prior. And then this is the ultrasound exam. So this is how she initially presented. We have a hypoechoic anechoic center with a peripheral echogenic rim to it. So the differential for this, just looking at it, certainly with a history of trauma, would be hematoma or fat necrosis. And then following up a month later, we see that this has significantly decreased in size, also reflecting the mammogram. Sometimes if you see, a slight decrease in size on the follow-up, it's a little hard to assign it a BI-RADS 2, but in this case, this is so impressively smaller in the context of assuming it's trauma-related that certainly this patient was assigned a BI-RADS 2 and no further follow-up was warranted. Okay, so in the last, less than half of the talk here, I've talked a lot about asymmetries, and this talk is multifaceted of asymmetries and distortions. So I thought the second part we can kind of go over architectural distortions. So what is it? I think this is sort of the really nuanced part of our job. I mean, certainly not the only nuanced part, but these can be very subtle and very hard sometimes. But in this case, architectural distortions, they're defined as basically the distortion of normal breast parenchyma without a visible mass. So basically the breast tissue is not orienting in a way that you would otherwise expect. Typically you can see kind of spicules radiating from a focal point. There can be focal retraction, and then there can be kind of straightening of the edges of the breast parenchyma. All of these things we can see with distortion. It's one of those things I tell the residents, it's hard to articulate what distortion is. You really have to see it. That's not the best way to educate someone, right? To say, oh, you just got to see it. And so we try as best we can to articulate what we're specifically looking for. But this, I think all of radiology is, very visual, of course. We have to see something rather than read it in a textbook. But this is certainly an example of that. What's our differential for architectural distortion? It's certainly very long. This is not comprehensive per se, but I did want to highlight some things. Unless you have an otherwise explanation for what the distortion represents, cancer has to be pretty high on your differential. One of the things that it can be is post-surgical. And in that case, that's a very good explanation for distortion. And in which case we say, okay, we don't even worry about it because we know that surgery can cause this type of distortion. If you don't have a procedure or surgery to really correlate to the finding, then you really have to take every distortion you see very seriously. Because it is a very common presentation of malignancies, both invasive ductal and invasive lobular. These are not the only two in the differential. Other benign things cause distortion. Trauma hematoma for sure. Radial scar is a very common explanation for why we see it. Same as complex sclerosing lesion, fibrosis, fat necrosis, all of these things can do it and can be considered concordant in the right setting. But I did just kind of want to draw your attention to these up here. I did want to slide on the differentiation between radial scar and complex sclerosing lesion because it is a very common benign etiology for architectural distortions. So for any of you that currently perform or will perform biopsies of architectural distortion, in terms of feeling comfortable calling concordance, radial scars, the distinction between these two is mostly size related. So pathologically, radial scars will be less than a centimeter, and then if it's over a centimeter, it's considered complex sclerosing lesion. In general, pathologically, complex sclerosing lesions just have more proliferative changes in the ducts around the scars, but criteria is largely size-based. In general, the management of radial scars and complex sclerosing lesions is evolving. It used to be standard practice to surgically remove these, worrying that there was more atypia or potentially cancerous cells that were harboring within the radial scar. That's happening less and less, but it's somewhat dependent if there's any atypia that is seen. If it's, I think still complex sclerosing lesions are usually removed. So if they get to a certain size, then they're taken out. But in general, the management is evolving, at least in our practice, and I think across the states. This is another really good utilization for tomosynthesis. It's almost always better seen. Architectural distortion is almost always better seen on the tomo. This is particularly true of dense tissue. So I mentioned this briefly earlier, but just to drive the point home, that tomosynthesis has shown to both reduce false positives from screening exams. So it decreases unnecessary callbacks, mostly from asymmetries and things that are ultimately just normal breast tissue. But the other part of it is that utilization of tomo also increases cancer detection, specifically of invasive cancers. So these are two really important utilizations of tomo. So I included some cases of distortions as well. So here, this is very subtle. I think I have the mammogram here. It's, very subtle in here, but I think the tomo shows it even better. This is very, very subtle. But if you can see here, I kind of blew it up to show you a little better. What we have, she's very, very dense. So it certainly wouldn't fault anyone for, attributing a lot of this to dense tissue, but you can kind of see there's a lot of just radiating spicules that we can see. This area is really what we're focusing in on. So this is where the true distortion lied. We did some spot compression views. It was found to persist. We sent them then to ultrasound. There was an irregular shaped mass that was seen at the 1 o'clock position on ultrasound. A biopsy was pursued, and this was invasive ductal carcinoma. This was another, certainly not to intimidate anyone. I did include some very subtle cases here, kind of the cases you don't ever want to forget. Usually it's much more obvious than this. So again, not meant to intimidate anyone, but this was found to represent some distortion. And so this was called for additional views. Again, quite subtle. There was a spot compression view with tomosynthesis that was utilized. This was found to be a mass with spiculated margins that we see here, low density, certainly very subtle. And this was found to represent invasive lobular carcinoma. So this is a nice example where I talked about, the subtle nature of invasive lobulars, and this certainly is, an example of that. This is another example of a 40-year-old on a screening exam with subtle architectural distortion in the central outer left breast. Spot compression views, again, quite subtle, but we can see kind of here that there's spicules that are radiating from a focal point. This also, I didn't write path on this. My apologies for it. I don't remember what the path was on this, so I can't speak to that. But what I can say is that this did undergo biopsy. This was found to be true distortion, and so it's just kind of an example of the subtle nature of the distortion. And then this is one last case that I have. This was an example more so of a focal asymmetry than anything, but this patient did have a history of invasive ductal carcinoma years past that underwent lumpectomy. You can see her surgical clips that were here within the upper inner right breast. On a subsequent mammogram follow-up after her lumpectomy, this focal asymmetry was found to be posterior to the lumpectomy bed, certainly quite subtle. Attention was drawn to it just because of its new nature. And then tomo, again, very, very subtle, but this was found to persist, and this was actually a recurrence of the lumpectomy bed, unfortunately. So I did, this was invasive ductal. I did leave you with some very subtle examples. So again, it's certainly not to intimidate anyone of reading mammography, or, if you already read it, but so I intentionally gave you subtle cases, but just to kind of show you the vast representation of how it can present. Those are my citation, and that's all I have today.
Thank you so much, Dr. Cubbison, for the highly educational lecture. Now it's time for Q&A. Please write your questions in the Q&A box at the bottom of the screen. Any questions? All right, seems like all the questions were answered in the lecture. Thank you so much, Dr. Cubbison. We look forward to having you again in the future. And thank you again. Have a great day.